Welcome everyone to our Research Journal Club for this December 2nd, 2021, when we will be discussing numerous perspectives, one goal, achieving optimal pain management in the inherited bleeding disorders community. Our speakers today will be Dr. Michelle Witkop and myself, Maria Santaella. We're very honored that one of our co-authors, Christy Humphries, will also be joining us at the end of this session so that we can discuss our findings and address your questions. So before we begin our mission, the National Hemophilia Foundation is dedicated to finding cures for inheritable blood disorders and to addressing and preventing the complications of these disorders through research, education, and advocacy, enabling people and families to thrive. So with this mission in mind, the purpose of our Research Journal Club is really to engage the inherited bleeding disorders community in discussing research that is relevant to current treatment and quality of life. We hope that this arena provides a professional, respectful space to engage in thought-provoking discussions, critical thinking, and perspective taking from all aspects of the community, all key holders that you see listed there. Our agenda today is going to provide us with a brief overview of the article, its objectives, methods, results, and conclusions. We'll discuss the findings and the impact of overall care in the community. And we'll open it for a Q&A with the authors and the audience engagement. So if you have any questions, please feel free to put them in the chat and we'll be addressing them later on. So the objective of this session is really to understand complications of pain with individuals with inherited bleeding disorders in connection to muscle and joint bleeding, to identify gaps in the CDC pain guidelines specific to individuals with inherited bleeding disorders, to learn opportunities for education, standardized tools, and applications to advance standards of care in addressing pain in the inherited bleeding disorders population. So this was our article, Understanding the Pain Management Landscape Within the U.S. Bleeding Disorders Community, a Multi-Center Survey. It was published earlier this year in the Journal of Pain Medicine. Okay, so a little bit of the background and the methods. So we all know that the United States have really been hit hard with the opioid epidemic. And we know between 1999 and 2016, over 630,000 persons in the US died from drug overdoses. And most of these deaths were due to opioids prescribed for pain. Anecdotally, because we really have no data for this, there have been numerous overdoses due to opioids and suicides said to be related to uncontrolled pain in our very own community. We also know that in 2016, the Centers for Disease Control and Prevention, the CDC, issued the CDC guideline for prescribing opioids for chronic pain. And really the goal of this was to help providers select the safest and most effective treatment for their patients experiencing chronic pain and requiring opioids. We know that pain is a known complication of individuals with inherited bleeding disorders, and to achieve optimal outcomes, including in pain management, persons with inherited bleeding disorders require coordinated expert hematologic multidisciplinary care and other ancillary services. HTCs are really viewed as experts in the diagnosis and management of inherited bleeding disorders, and as such, they're frequently tasked with the management of pain associated with these conditions. So the objectives of our study was the following. So we explored the practice patterns related to pain management in hemophilia treatment centers in the United States with the aim to describe pain management practice patterns within them, identify gaps and areas of alignment with the CDC pain guideline, and address educational opportunities for pain management. Methods, again. So this descriptive study involved physicians, nurse practitioners, nurses, physical therapists, and social workers from federally funded HTCs that were eligible to complete an online survey exploring pain management practice patterns within as they related to the CDC guideline. The study was IRB approved. It used Qualtrics as a survey platform. And it was developed by the MESAC Pain Initiative Multidisciplinary Task Force. This task force was formed in 2017, and it consists of 3 physicians, 2 nurse practitioners, 1 doctor in nursing practice, 1 registered nurse, 2 social workers, 2 psychologists, 3 therapists, 2 patients, or like we now like to refer them, subject matter experts, and 1 statistician. Since then, we've added 1 pharmacist to the group. But anyway, this survey was created by this task force, but it was not formally validated or previously tested. The survey was based, like I said, on the CDC 2016 guidelines for prescribing opioids for chronic pain and included HTC demographics, so things such as location, patient population, percentage of patients they treated with pain, and percentage on opioids. Provider practice patterns such as the use of pain assessment tools, frequency of the assessment, use of non-pharmacological pain options, comfort with managing pain, and then tools, we assess for the use of tools to monitor opioid management and assess access to pain specialists and additional services. 16 questions were common between all 3 provider groups, which you see on the bottom. Physician, advanced practice providers and nurses is a group, social workers another group, physical therapy is another group. 3 were common between 2 groups, and 42 were provider specific. So each one of the groups had specific questions. A table linked to the manuscript lists the survey questions with a crosswalk indicating common questions between the groups and those that were specific to each of them. So invitations were sent to every identified provider within the HTC network, and we pulled their email addresses from the CDC directory at the time. They went out May 7th, 2018, and weekly reminders were sent until the participant took the survey, the participant opted out, or the 9-week survey time frame ended. Hence our study. The objectives of the study was to, this study came about because we wanted to explore the practice patterns related to pain management in hemophilia treatment centers in the US. And so the particular study aimed to describe pain management practices, patterns of HTC providers, identify gaps and areas of alignment with the CDC pain guidelines, and address educational opportunities for pain management. Next slide, please. So in this descriptive study, we created a survey. It involved physicians, nurse practitioners, nurses, physical therapists, and social workers that worked in federally funded HTCs that were eligible to complete the survey. And the survey, like I said, was exploring pain management practice patterns associated with the CDC guidelines. Next. Obviously, it was IRB approved. We use Qualtrics as a survey platforms to send these invitations for the surveys. The Pain Initiative Multidisciplinary MESAC Pain Task Force, it's a mouthful. It's a task force that was formed by MESAC in 2017. And it consists of physicians, 3 physicians, 2 nurse practitioners, 1 doctor of nursing practice, 1 registered nurse, 2 social workers, 2 psychologists, 3 physical therapists, 2 patients, and 1 statistician. And since this study, we've added a pharmacist. So this task force developed a survey, which was not formally validated or previously tested, before this survey was conducted, the study was conducted. The survey was based on the CDC 2016 guidelines for prescribing opioids for chronic pain, and it included everything that you see here. So we looked at HTC demographics, location, patient population, percentage of patients with IBDs that they treated for pain, how much they prescribed the opioids, and practice patterns such as the use of assessment tools, frequency of assessment, and their comfort with managing pain, tools for monitoring opioid management, and access to pain specialists and additional services. So a little bit of everything. Next slide, please. There were 16 questions that were common between all three provider groups. So the provider groups are down there: physician, advanced practice providers, nurse, or PAPPN, social work, SW, physical therapy, PT. So 16 of the questions were common for all of them. 3 questions were common between 2 of the groups, and then 42 were provider specific. And if you go to the article, there is a table that is linked to the manuscript that has a crosswalk of other questions that we asked and which are the commons between which of the groups. They had to do obviously with their role within the HTCs. So invitations were sent to every person identified, every provider identified in the CDC directory. We did it starting May 7th of 2018. And weekly reminders were sent until either the participant took the survey, the participant opted out of the survey, or the 9-week survey timeframe was completed. Next, please. And so now I will hand it over to Michelle. She will discuss the results, conclusions, and then we'll open it up for discussion. Go ahead, Michelle.
That was quick. I didn't expect to be on so fast. Thanks, Maria. So in this results section, we're going to talk about the effectiveness of the pain management programs that the HTCs have, the utilization of the non-pharmacologic pain management options, trials of non-opioid medications, maintaining follow-up, recognizing and utilizing clinically important findings prior to opioid treatment, and counseling and education on potential risk factors. First off, the demographics. We sent out the invitations to over 1,000 participants. 37 bounced back, 330 started the survey, and 236 providers answered all of the survey questions. This gave us a response rate of 23%. All 12 US regions were represented, and there really was no statistically significant difference in the ratio of the provider type based upon the regions. When we looked at the physician, advanced practice, and nurse provider group, there were 141 in that group. And from now forward, I'm going to call them the prescriber group. There were 77 physicians that identified as hematologists, which made up the majority of this group, 42 registered nurses, 18 NPs, and 4 PAs. And one of the questions that we asked was how effective they felt their HTC managed pain. And most of them felt that they managed pain either moderately or very well. The social workers were more likely than the other 2 groups to indicate that their HTC managed pain either not well or only slightly well at 33%, compared to the prescriber group at 10% and the PT group at 7%. Then we went on to look at the professional role in evaluation and treatment, and more than 90% of the respondents in the both the prescriber and the PT group personally evaluated pain and this is in the entire bleeding disorder community, not just hemophilia, but in all persons with bleeding disorder. So that was compared to 47% in the social work group. Those in the prescriber group and the PT group were more likely to also use a formal pain measurement tool compared to the social work group. And the majority of them use the numeric rating scale. So when we think about that, that is that 1 to 10, on a scale of 1 to 10, where's your pain? The majority use that scale. The most common reason given for not personally evaluating pain was that it was assessed by another discipline. And there were specifically 1 or 2 social worker PTs who stated that it was not part of their evaluation. And now this question was only asked of the PT and social work group, and we asked about their comfort level with making recommendations, specifically non-pharmacologic recommendations. And the PT group felt moderately to very comfortable with making those recommendations, as you can see, and the social work group felt somewhat comfortable, and specifically about providing pain management counseling to persons with bleeding disorders. When we looked at the PT respondents and what they were likely to recommend from a non-pharmacologic standpoint, they were most likely to recommend orthotics, splints, aquatic therapy, surgery, massage, and yoga. So very physical, hands-on types of things. And when we looked at the social work group, they were more likely to do more of those psychosocial interventions, cognitive interventions, such as mindfulness, cognitive behavioral therapy, distraction, and meditation. When social workers provided pain management counseling, it was usually through the annual comprehensive clinic visit. Next came telephone consultations. They would also do individual sessions based upon needs. And there were some that did home visits, and this was, they also were doing teleconsults. Now, this study was done before the pandemic, so I would imagine that teleconsults and telemedicine is now much more pervasive than it was at that time. Again, this was done in 2018. So at that point, less than half of the social workers indicated that they assessed and provided interventions for needle phobia and aversion to getting clotting factor intravenously. And those who did not provide pain management counseling stated that they weren't expected to do so or did not have the skills or training to do so. When we looked at the non-pharmacologic modalities and education, the prescriber group and the PT group were most likely to educate their patient population on non-pharmacologic, or also, as we call it, complementary treatment modalities for pain management, as you can see. And when we asked them what percentage of your patients do you educate on this, it was a fairly good patient population. You can see the PTs educated about 67 or 65% of their patient population, the prescribers 58%, and the social workers 28% when it came to complementary treatment modalities. We also asked them then what were the barriers to making non-pharmacologic recommendations. And the biggest barrier across across all groups was a lack of knowledge, specifically regarding risks and costs. Then came distance traveled. So not actually, that would relate to access for the person. And then just not having the time to be able to spend to talk about this type of treatment. And then the treatment's not being offered at their treatment center. So again, familiarity. So now we're going to get into the pharmacologic aspect of this. When we asked about the most frequently recommended non-opioid pharmacologic management, only the prescriber group, the physician, advanced practice, and nursing groups were asked about pharmacologic therapy. 88 providers, or 62%, said that they trialed at least 3 of the 6 therapies that you see on the right-hand side of your screen prior to initiating opioids. And the most frequently recommended treatments were starting, and you can see at the top, we have acetaminophen, also known as Tylenol, COX-2 non-steroidals, and those are your Celebrex. We used to have others, but Celebrex is the main one right now. Factor replacement, neuroleptics. So neuroleptics are your gabapentin, Lyrica, things like that. Antidepressants, and then your COX-1 non-steroidals, and those would be your ibuprofen, naproxen, those types of medication. So those were the most popular non-opioid management, and those most people would trial some of those prior to initiating opioids. And this is in alignment with the CDC guidelines. We did ask 3 general questions of the prescribers about opioid therapy, specifically for acute and chronic pain. And you can see on the left-hand side, we asked them to estimate the percentage of their patients who actively used opioids for acute pain. And 16% said none of their patients used opioids for acute pain. So that meant, of course, that you have over 80% who are using opioids for acute pain. And the same with chronic pain, 32% said none of their patients used opioids. And so then you've got a good percentage of them saying that they have patients who use opioids for chronic pain. And then both acute and chronic pain, 52% said that none of their patients used both of them, both long and short, or both opioids for both acute and chronic pain. Now, again, we said we had 141 prescribers. Only 97 reported that they prescribed opioids. So there was a group that did not prescribe opioids. And of those who did not prescribe opioids, specifically, there were some that chose not to due to concerns of patients potentially misusing the medications or the concerns of difficulty monitoring opioid use. So again, looking at that alignment with the CDC guidelines, and because we weren't sure about the time frame we would have today, we didn't put the CDC guidelines in here specifically. But one of the, or some of the things that they recommend fall in alignment here. And when we look at initiating or reviewing opioid therapy, 96% of the opioid prescribers consistently reviewed opioid risks and benefits with their patients, which again is in alignment with the CDC guidelines. 44% used an opioid agreement. And that is basically just setting goals and putting out some guidelines or some formalities as to how are we going to write this out? How are we going to prescribe it? What are the things you're going to do? What are the things I'm going to do as a prescriber? And it just lays that out. It's not a contract, as many people often will refer to it. It's just a medication agreement, and it just puts out what are the expectations. 25% of the prescribers obtained written measurable goals, which is really important. And they really should be based upon function. And as we can see, the vast majority of them that did do written goals based them upon function. So are you getting benefit from this medication? Is it improving your ability to get up and get around and do the things that you want to do? Another 54% of the people who did written measurable goals based them also upon adverse effects of the medication. If they're causing problems for you, then we're going to make changes. Another 54% based them upon self-management techniques. Are they helping you to do things better for yourself? And then a small group also looked at the numeric pain scale. And so if you stated that your pain was a 5, how much did it come down from that? Did it come down to a 3 or a 2? And what is your goal for that pain scale to come down to? 25% had a written plan for discontinuation of opioid therapy. So again, if you have side effects, if this isn't helping you to do the things that you want to do in your life, then we are going to do something other than the opioids, and we're not going to just continue them because we started them. 20% used a formal screening tool. And the CDC recommends that as you start, and I'm going to go to this next page, as you start using a medication, that you should consider using a screening tool such as what you see here. This is the opioid risk assessment tool. And this is something that helps you to evaluate a person's personal risk for using opioids and whether or not that they will misuse them. Now, it's not 100% accurate, and of course, there are people who will do fine, but the higher your rate in this risk, the more you need to be observed, the more you probably need to have a pain specialist involved, the more rigid your plan should be. So when we ask people, very few of them use that formal tool, but the majority of prescribers, when asked, did they rank or did they look at some of these specific clinical findings that were included in that screening tool? They did. We asked them on a scale of 1 to 5 how important these things were. And as you can see from these items below, these were what received a ranking of 4 or above. So they considered them very important. And that is a prior non-fatal overdose, current regimen including opioids or benzodiazepines. When you're combining a benzodiazepine as well as an opioid, there's increased risk. So that's something to take into consideration. A history of positive drug screen for illicit substances, a personal or family history of substance use disorder, and a patient description of their pain symptoms. Are they congruent with what their pain should be? The intensity of pain and their functional ability. So taking all of those things into consideration when we go back to this opioid risk tool, many of those things are in this opioid risk tool. So even though they weren't necessarily using this formal tool, they were considering many of those things that were in that tool before starting opioids on their patients. So they were pretty aligned with the CDC guidelines. The other thing that the CDC recommends is a prescription drug monitoring program. And there's a link right here that can take you, and you'll have access to these slides, but this link will take you to the CDC's information on these programs. And every state has them now, where you can go in and monitor patients' prescriptions and their fills through pharmacies for prescription drugs. And it's not just opioids, but it's benzodiazepines and other controlled medications. And the majority of the people who responded, the prescribers who responded to this survey, utilized their state prescription drug monitoring program. And you can see that many of them they all used it on a different scale. Many of them used it on a monthly basis. So when patients were coming in for their refills, they were checking that before they refilled the opioids to make sure that they weren't getting them from some other place. And that's really important to do. Now, every state is a little bit different as to how up to date it is, but you're going to be able to get a pattern, especially if you're checking it on a regular basis. To understand how accurate or how compliant your patient is. And you're going to be able to pick up if they're filling opioids legally through a pharmacy, or if they're getting other medications through an emergency room or another provider. By monitoring this program. So I'd strongly encourage you, if you have not signed up for your drug monitoring program through your state, that you do so and that you monitor it. As for urine drug screens and concurrent cannabis use, this is really a hot topic now. And something that everybody probably needs to consider from a policy standpoint, what they're going to do. Because cannabis is legal in many states from a recreational perspective as well as from a medicinal perspective. So again, we asked this a couple of years ago, but when the prescriber was aware of cannabis use, 20% would not prescribe an opioid. 80% would prescribe an opioid on a case, but it depended. About 61% would prescribe on a case-by-case basis. So again, based on many of those things that we talked about before, knowing their family history. And I think that that is the benefit of our HTC system, is that you really know these people well. You know their families, you know their family history, you know them longitudinally. So it's not like you are just meeting somebody for the first time. And then 20% would prescribe when they felt it was indicated. We asked about urine drug screening, and amazingly, 59% utilized them. And again, you can see how that broke down. It wasn't that they were doing it every month. Some of them were doing only when they suspected a problem. Others were doing it randomly. Some were doing it monthly or every 3 months or on a yearly basis. I come from a background where I worked in a chronic pain clinic for a number of years, and we would randomly screen a number of our patients every day. So we had 3 or 4 providers every day seeing patients, and we would be seeing, up to 20 patients a day. And it would be a matter of, we just pick somebody. And it might be somebody in the office, it might be a patient, could be the janitor. And we'd say, give us 3 numbers. All of them are between 1 and 20. And, they could say 5, 10, and 14. And so on one prescriber, it'd be 5, on the 5th patient, on the next prescriber, it'd be 10th patient, and the next prescriber, it'd be the 14th patient. And they would get urine drug screens. That's how we did random. And as you are seeing patients, you can decide how your random is going to be. But every time we saw patients who were taking opioids, we would do a random drug screen in that manner. One of the CDC guidelines is about follow-up after you're initiating opioid therapy. So we asked our prescribers, how do you follow up with them? And the vast majority had an initial call after starting opioids or changing them within 9 days. So 72% contacted patients in less than 9 days after initiating opioids. And that was to evaluate the safety, make sure they weren't having side effects, and to balance that benefit and harm, to make sure that they were doing okay. And then 96% had a continual reassessment of that risks and benefits. So every time they saw them, they were checking in on the side effects and the benefits of it. 44% had opioid agreement documents. Again, the 20% used the formal tools. And then we have the measurable goals. So you can see the same thing we had talked about previously here. We did ask about resources used to manage chronic pain, and we asked this of all of the groups. And there was quite a large list. This is only the top. What do I have? 2, 4, 6, 7. The top 7 from the resources that were available, and you can see that pain specialists was across the board the top resource used. For the prescriber group, it was the top resource. For the PTs, it was second, and for the social workers, it was first. And as we go down the state monitoring drug program, For, of course, the prescribers, that was the second. It was not as utilized for PT or social workers. Psychology was a high number for all of them, and behavioral health was a fairly high number for all of them. So you can see that these are very positive interventions, both from having available resources, from monitoring, and that psychosocial background. And then the alternative, non-pharmacologic, was fourth for PT. It was down there for the others, but it still was pretty high. There were difficulties in accessing pain specialists, and that ranged from 36% to 67% in the different groups, but the most common was access. Just even having a pain specialist that you had access to was difficult. And there was a lack of providers. Insurance or cost was an issue. And then one of the issues that we have across the board is that there are many pain specialists that are unwilling to just manage opioids. Many of them are what we call block clinics. They want to do injections. And for our population, that just isn't really what we want, or is not safe for our patients. You know, we don't want them having epidurals. We don't want needles put into their spines. So we would, if we want them to have anything, we would prefer that they help us in managing the opioids. So finding a pain specialist who's willing to do that, even co-manage with you, can be difficult at times. So in conclusion, what we found through this survey is that there are opportunities to incorporate the consistent use of tools and standardization to the development of policies and procedures in clinical practice. And those formal screening tools, questionnaires, opioid use agreements, and written measurable goals are what's important for us to consider. We really should have written policies and procedures incorporating these. They should be standardized, and we should be using them on a regular basis. We should all be using prescription monitoring programs, and we should all have a written plan for discontinuation of opioid therapy. Whether it is causing adverse events, it's not meeting the goals, or they just have been able to utilize non-pharmacologic management and they don't need opioids any longer. And overall, there are educational opportunities for HTC team members, as well as our community. The individuals with bleeding disorders who are experiencing pain, we have opportunities to educate them on pain management, and whether that's opioid pain management or whether it's a non-pharmacologic pain management. There are a lot of opportunities out there for all of us. So with that, I would like to open this up to discussion, and would like to bring back our members of our panel and introduce them real quickly. We have Christy Humphrey, who is a social worker from Hemophilia of Georgia in Atlanta, Georgia, and she is a co-author with us. We've got Maria Santaella, who is my colleague at NHF. And we have, I'm not sure, Kevin Mills, if you're able to join us or not. He is our Chief Scientific Officer at NHF. I see him on the screen, but I'm not sure if he's in a spot that he can join us or not, but he's more than welcome to. And then Samantha's going to help us if there are any questions that we have from the group. but I'd like to sort of open up the discussion with Christy. One of the things that I talked about in the results section was the difference between the satisfaction. In a study that I had done with Angela Lambing years ago, the National Pain Study, 39% of participants, and those were persons with hemophilia, stated that their pain was not well managed by HTCs. And in this study, we asked, how well do you feel you manage, your HTC manages pain? And the majority felt that they did well, but we still had a good percentage of social workers specifically, but there were others. 33% of the social workers respondents felt that they did not do as good a job as they could. And I'm just wondering if you'd like to speak to that.
So it's a really interesting question because I find it interesting that the social workers sort of tracked very much with what the clients were saying. And I think this speaks to the different kinds of relationships that, you know, doctors have with patients, that nurses have with patients, and that social workers have with patients. I can tell you a personal story. I've got clients who, you know, I go out into the homes, I do home visits as part of my job, and we're sitting there and we're having conversations about, well, how is it going with getting around, and how is it going with this or that? And one client in particular I can think of, and this has happened multiple times, this isn't just one guy, one time, where he said to me, you know, I'm really struggling with pain to the point that I'm literally shaking. Like when I stand in my shower, I'm shaking. And I said, so did you talk to your doctor about that? And he says, no. And I say, well, help me understand, like, why wouldn't you tell your doctor about this pain? And he said, because I don't want to be seen as a drug addict. And I don't want to be seen as someone who's seeking after something in order to, you know, make me look bad. It will make me look bad. And I will tell you, I was even at the treatment center one day with this guy, and we were talking about, he was talking to me about disability, and the provider came in and he said, everything's great. Everything's fine. I mean, seriously, said these very disparate things. And so it becomes this question within the context of the treatment center. When they're there for a very long time, for hours sometimes, but at the same time too, how much time do they have with each provider? And I know as a social worker, you know, there's time for the doctor and sometimes there's time for me. And so it becomes this question of how we approach and what to say. I do think what the social workers are seeing is accurate. And I don't know that we're always, the clients are always very comfortable in saying the complete and whole story because they're so worried. They know this is a long-term relationship and they know that they need you and they need you desperately. And they know they need to stay on your good side. Believe it or not, that really is a dynamic in the midst of this. And so it's this question of how does all the providers become a safe place to fall, right? And so it's one thing to tell me, and then I can advocate and, you know, I can say, you know, things in the background, but it's another thing for them to feel very comfortable saying right out loud what their actual experience is.
I would agree with you. And I think we all know that because of relationships, we all get different parts of that person's journey in a comp clinic visit. So what you might get is going to be different than what I might get, what a physical therapist might get. And what's important is that we put all of that together at the end of the day, so that we get a full picture of what that journey looks like and what their experiences look like. So I would agree with you. And interestingly, I've done talks on pain and had people tell me all kinds of stories about their pain and the severity of it and how it impacts their life. And they literally have said to me, but when I walk out that door, I will not tell anybody what I just said to you. You know, they admit that they have a face for the public, and then they have a face that they present in certain ways. So it is interesting. We become detectives.
There is a follow-up question to that might pertain to your line of thought there with, is there a connection between mental health and pain?
Is there a connection between mental health and pain?
Is there an association between pain and mental health? That's one of the questions in our chat.
I'll let you take that, Christy.
Yes, and the answer is absolutely. There has to be, and the reason is very biologically based. It turns out that the same part of the brain that registers pain is the emotion center of the brain. So all pain is emotional, period. It just has to be. And so what's very interesting, we have to look at the biological, we have to look at the psychological, but then value systems and belief systems actually have a particular way of developing pain symptoms as well. It's very interesting. We have this wonderful researcher in Durben, England, who is a psychologist, Dr. Elander, and he has done some really interesting work. And he came and spoke with the social workers this past year and has demonstrated that pain intensity is actually influenced by quality of life. Pain willingness influences pain intensity, and negative thoughts increase the actual pain symptoms as well. So yes, mental health and pain have to go together, which is one of the reasons why it is so important to include the social worker. And we did have a question in the chat about the social work component of this. And so, you know, it is very important to include the social worker, but remember the social workers have a lot of responsibility that are case management based. And so not every treatment center actually wants the social worker to focus on counseling aspects of any sort. I even know of one hospital in particular who actively discourages any counseling duties. They want them to focus on case management and case management only. So we've got some challenges in, are you part-time as a social worker? Are you full-time as a social worker? Some of the HTCs would prefer the social worker to focus only on case management tasks. And then there's also the tone set within by the other medical providers. Does the doctor and the nurse want to just assess pain? Now, usually the social worker could kind of come around, and remember that about 58% of the social workers are doing counseling and not just case management. So, you know, these interventions are happening in the hemophilia community. And I know I'm personally trained in mindfulness-based stress reduction and cognitive therapy and ask those questions as well. And so unfortunately, because there's not a single way that a hemophilia treatment center addresses a thing, you're going to have different responses from social workers as a result of that. And then sometimes the tone is set either within the HTC or within the hospital system and focuses the work of the social worker as well.
I think then that's important for us to encourage our community members, our chapters and our community members to advocate for themselves, to be able to say, if we can't get this in our HTC, that there's a referral out to someone else then. You know, we would hope that we could get it into the HTC, but if we can't, then where else can we? And that would come, you know, if we can't advocate for that internally, then we should have our patients being able to advocate for that too. I'm sorry, Samantha, I cut you off.
And remember, the research and even the CDC guidelines say a multimodal approach is the way to go about good pain management. And there are many aspects of the guidelines that address psychosocial needs directly. And they even say to use psychosocial techniques first, actually. And so if like the local social worker is not trained in cognitive therapy, definitely, you know, ask about, can you help me find someone? Because of course, the resources always start with your insurance. or lack thereof of insurance. And so getting connected sometimes is a like 4 or 5 time discussion just to get, you know, the ball rolling. And then, so it's really, I agree with you. It's about partnering, and it's really about looking at this from a very broad perspective. And then not just advocating for yourself, but asking the questions directly. What, you know, I am very worried about pain. I know that pain is bigger than just taking a pill. Actually, when you look in the research, they say that pills, opioids, can only decrease pain symptoms by about 30%. Mindfulness-based stress reduction, 30 to 50%, cognitive therapy, about 50%. Imagine if we're stacking these techniques one on top of the other, and then add in physical therapy, and then we're off to the races, right? So, you know, we can really affect this in some kind of way, but it does not mean that we're going to cure pain. That's the other thing, you know, setting up realistic expectations and this idea of pain willingness and how you work with the actual symptoms themselves matters as well.
Absolutely. Absolutely. Samantha, did you state that you had another question?
Yep, that actually ties into some of the multidisciplinary questions that are in the chat and conversations around standardized tools and prescribing. Can we transition into those arenas? It looks like there's a question about Celebrex with bleeding disorders and pain management.
So it is, let's see, can we, is it a question of, can we use Celebrex?
It reads, it's my understanding Celebrex can interfere with platelets. And when I tried Celebrex, I had an increase in bleed, nosebleeds, joints, thoughts, factor 9 deficiency, and von Willebrand's type 1.
Okay, well, and there's a difference between the different anti-inflammatories, and Celebrex is what we call a COX-2, so it has less platelet issues than like your ibuprofen and your naproxen. Doesn't mean that there won't be any, and it might be that you as you are more sensitive to that. So certainly working with your provider on an alternative method. And some of the things that have come out in the literature recently is topical anti-inflammatories. They don't have such a systemic effect. So meaning that they don't enter your system all the way around as a pill will. A pill will affect you all around, whereas when you put it on topically, you're just rubbing it into an area. It just goes into the tissues right there. And so that might be beneficial for our population to look at topical medications. And it doesn't necessarily just have to be a non-steroidal. It could be other medications too, or other types of things that you can put in topically that can help with your pain. So something to consider there. Were there other, from the perspective of standardized tools, were there other questions? I have to go in and look and see. I haven't pulled up
that addresses our questions about standardized tools, but we do only have about 8 minutes left, and there's 2 questions. I think, Maria, you were going to address one of them.
To what extent does the patient's perception and description of their pain affect their pain management approach, how follow-up and success of pain management?
Can I nerd out for a second? I heard the time. I heard it. I'll try to be brief, but you know that's hard for me. Perception of pain does matter, always, and it has to do with the fact that the brain itself knows how to create its own analgesia based on what you believe. I know you're like, excuse me, but yes, there is a study by Solomon and Johnson that came out in 2007 that you can look up. And it turns out that there's 3 parts of the brain that know how to work together to actually create analgesia. So what you believe about pain and your experience of pain actually matters tremendously. But due to time constraints, I will leave it there. I could go on all day.
I would agree with you 100%, Christy. And, you know, we talk about the placebo effect, and we're not talking about drugs here, you know, fake drugs. We're talking about just the fact that your brain believes it. 30% of the time it will happen. So what is there? There's that, their mantra, if you believe it, it will be. That can happen with pain too. If you truly believe something is going to happen, your brain can help. And it's an unleashed power that we don't use. And from a provider's perspective, that encouragement to patients, for the providers who are on the call, to really be able to be positive and to support somebody in their attempt to deal with pain from a non-pharmacologic perspective, to support them in doing mindfulness, to support them in seeking out ways to be physically active, knowing that this is not going to, you know, that their pain is not going to be the demise of them. Being physically active is going to actually help them. It's going to build the stronger muscles that will support their joints and help them to decrease their pain. So
May I add something? But be very careful in how you approach that topic. If they come away with an understanding that this is quote unquote all in their head, we're talking about and situations, right? So it's medicine and mindfulness and perception. It is not an or and it's all in your head. If they get that messaging in any, like even a whiff of it, they are going to shut down and then not talk to you any further about what's going on for real. So that's just the one addendum I have to say. And I agree with Michelle 100%. It's about being encouraging. And when the doctor, I can tell you, it goes much further. Like I can talk all day about mindfulness, but when the doctor's like, and by the way, you know, there's mindfulness that can help you, it just goes further. It has to do with power structure and dynamic. It just is what it is.
Yeah, I would agree. So we just have a couple of minutes.
Yeah, there's another question that I think would be good to wrap up, kind of like conclude and, you know, close the session nicely, that says, what is the most effective way to implement the conclusions of the paper? Is it publications, webinars, sessions at regional, national meetings? What are our thoughts?
So a couple of things. We are working on some subsequent papers. Our physical therapy group has submitted a paper to hematology on the PT perspective. Christy and some social workers are working on a social work perspective. We have some pain modules in Partners PRN, which is a collaboration with the Partners program and NHF. And we're hoping that those will go live, and those are CME education programs so that we can educate our HTC partners on pain. And I think there's 3 or 4 of them that are in their final review. I'm seeing that come through my emails every day. So I'm hoping that those will go live soon. And out of this came our MASAC guidelines, which were very important and give up more structure to the community as to how to deal with opioid management and chronic pain. And we also have another publication that's going to be coming out about the development of those opioid guidelines. So all of this give us a foundation for our pain management in this community. And it's something that we need to continue to educate on, we need to continue to advocate for, and we need to continue to research. So with that, I think I'm going to turn this back over to Samantha.
Thank you. We had a couple questions in the chat, and what a robust discussion. We will certainly bring this back for consideration for a topic for next year, because obviously there was a lot of engagement. We appreciate that. This is recorded. It will be posted later this month. There will be enduring credits for nursing, physicians, and advanced practice providers. You will receive an email code and instructions on how to fill that out to get your CEs. And you will receive that at the latest on Monday, but we're hopeful for tomorrow. And with that, I'll hand it to Michelle for closeout. Thanks.
Thank you, Samantha. And thank you to our speakers today, to Christy and to Maria, Samantha, and to Kevin, to NHF for supporting this. It's important that we get pain education out to the community as a whole. To all of our participants who have joined us today, we appreciate your time and your attention. And please just let us know what you think about this and where you want us to go with this. Your question as to what are the next steps? What do you think from a pain initiative standpoint we should be doing next? Because we do have our MASAC group. So we're open to any suggestions that you have. Thank you and have a good rest of your day and have a happy and safe holiday season. Bye-bye.